COVID-19 has quickly brought about many changes in the way hospitals manage and care for their patients. As hospitals across the nation begin to see an influx of COVID-19 patients and shortages of ICU beds, Atrium Health sought to lead the way in finding a solution to increasing their inpatient capacity. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly, Senior Writer for AHA. In today's episode, Elisa Arespacochaga, Vice President of AHA's Physician Alliance, sits down with two leaders from Atrium Health in North Carolina to discuss how they've implemented a virtual hospital to increase their capacity to care for their COVID-19 patients.
Welcome to another podcast in the American Hospital Association's ongoing series where we focus on important issues facing clinician leaders. I'm Elisa Arespacochaga, Vice President of AHA's Physician Alliance, and today I'm delighted to be joined by Rob Rose, Chief Nurse Executive of the Central Market at Atrium Health, and Colleen Hull, Vice President at Atrium Health. And we're going to explore a little bit about how Atrium Health is managing their COVID-19 patients through the use of a virtual hospital. To get us started, Rob and Colleen, can you tell me a little bit about yourself and your organization? Rob, let's start with you.
Sure. Again, my name is Rob Rose, and I serve as the Chief Nurse Exec for our Atrium Health Central Market. That market is our market in the greater Charlotte area. I'm responsible for nursing across 3 hospital campuses, our flagship academic medical center, Carolinas Medical Center, our Children's Hospital, Levine Children's Hospital, and our community hospital, Mercy Hospital, which is geographically about a mile away from the flagship hospital. In addition, I have nursing practice for the provider-based clinics.
Great. And Colleen?
Good afternoon. My name is Colleen Hull. I serve really in 2 roles here at Atrium Health. First, as Vice President of Clinical Integration and Population Health. And in that role, primarily, I work to integrate the principles of population health and value-based care into clinical and operational practice. So I focus largely in the ambulatory space, which is essentially the foundation of population health. In addition, I serve as the Chief Nurse Executive of the medical group, which is a large 3,000-member medical group. Again, focused largely in ambulatory care, but also integrating the hospital-based clinicians in that role as well.
Wow, you both have pretty big jobs. So I know this came up because Rob mentioned the work that you had put together on the virtual hospital as a way to treat your COVID patients. And Colleen, let me start with you. Can you tell us a little bit about what this virtual hospital is and what was the impetus to really create it?
Really, it was initially thought of as we are going to take care of patients outside of the hospital with mild symptoms that would likely do just fine. But quickly we recognized there were patients who probably would qualify for an inpatient stay, but our concern was capacity. And we were watching across the country really crisis happening, particularly in urban hospitals that were filling their hospitals and ICUs. So we recognized we need to be part of the answer to develop, or I should say increase, our inpatient bed capacity. In addition, we wanted to keep patients mostly in their homes, so to limit community transmission was another one of our agenda items. So essentially, we started on a weekend, and about 10 days later, after pretty much around-the-clock planning, we're able to see our first patient. The hospital was really divided into 2 units, and we used the construct of a hospital because it was familiar to people. The whole concept of admission, discharge, and transfers was familiar. We could think of it as admissions and beds and patients in beds. So we established 2 units, really. Sometimes we referred to them as floors, just like we do in a hospital. One was observation care, and that really was is for patients with mild symptoms. They receive telephonic RN assessment and monitoring. And then the second floor, or the acute unit, was for patients with moderate symptoms who truly otherwise would have been admitted to Rob's hospital, for example, a brick and mortar hospital. In addition to those observation type monitoring and assessments, these patients also receive a daily in-home visit by a community paramedic or a nurse. And they're able to administer IV fluids, medications, able to draw lab work, perform EKGs, respiratory treatments, and other interventions. Essentially the care really that they would have received as an inpatient, but because we were able to really muster resources that we already had in place focused on this population, we were able to care for these patients at home. And then on top of all of that, we put in the Get Well loop, which I think many of your listeners would be familiar with, really a patient engagement app that's accessible from the patient's device, the phone or laptop computer, that lets us interact with the patient really around the clock, bidirectionally. So the patient will receive periodic reminders and education and prompts to which they can respond, particularly around their symptoms. So we then would receive alerts based on the patient's responses. And that allows us to really escalate care before the patient is really in trouble. So really, to date, about 95% of all of our Atrium positive patients have been touched by the virtual hospital, either on the observation floor, which is by far the most of them, and then the rest in the acute unit, and really only needed to transfer around 2% of those patients back to brick and mortar hospitals.
Rob, anything to add to that description?
No, I think Colleen said it very well. What I would say is we were so concerned about our volume, particularly in the central market. We're in a big metropolitan area, as well as having capacity issues on a good day. So having the pandemic outbreak, in addition to what we were seeing, we were very concerned what it would look like going forward, obviously with a lot of planning. So the virtual hospital was really a lifesaver for us.
So tell me a little bit, Colleen, about how you're measuring outcomes and really evaluating the success of this, and what do your patients think?
I would say we have yet to really step back and look at and really perform analyses on the outcomes, but just really some process measures. At Atrium, we were blessed. We were able to actually do in-home tests, or I should say in-house testing. So we've done more than 70,000 COVID tests. Of that, on average, we're averaging about 9% positive, or close to 7,000 tests. As I mentioned, high percentage of those patients have been admitted to the virtual hospital instead of brick and mortar. So as Rob just mentioned, an outcome of being able to avoid an admission and shorten a length of stay of a patient that initially did have to be admitted. I would call that certainly a success. Very few of our patients have opted out, so we successfully were able to keep the patients engaged. As a lot of folks have seen, somewhere around day 5 to 7, some patients who were doing great all of a sudden have a sudden and severe exacerbation, and we were able to keep an eye on those folks and avert a sudden admission, even though they thought they were probably going to do fine. As I mentioned a moment ago, only about 2% of our patients that were in the virtual hospital had to be transferred to acute care, usually for the escalation I just mentioned. So we were able to avoid admissions, again, keeping the hospital able to take care of the sickest patients. We discharged 70% or so. We used CDC and World Health criteria to discharge those patients, but really our greatest success, I would say, comes from our patients, which one could still say is anecdotal and not science, but essentially what we did it for. Things that we've heard from patients, I've made some notes here. It was easy to access medical professionals. They took time to speak with me and generally cared about me. It was great. My questions were answered quickly. The reminders were helpful. It relieved my stress. I was healthy before COVID, so this was new. The quick responses were sure and definite. Glad to know someone was keeping an eye on me throughout this whole experience, and I wasn't alone. So I would say the theme largely, for those that weren't sick enough to be in the hospital, was managing fear and anxiety in addition to their clinical care. And I know for certain we were successful at doing that, just really wrapping the patient around care, even though it was virtual. We also had patients tell us, even though I can't be present with you in my doctor's office, I feel safe and cared for. And I guess the other success I would say is this has given us really a chance to test and improve many of the processes and technologies that we already had capability to do, but had not yet had an impetus to test it on scale. technology, for example, we got lots of experience with the Get Well Loop, and there are many of those sorts of patient engagement applications that we know we could apply to other populations, particularly our complex chronic patients. But we know that an app alone is not care, and that many patients just really need that personal touch as well. So I think they go hand in hand. We also learned that some patients just need a personal, real-time interaction to manage fear and anxiety. We're trying to test how to keep patients engaged through technology. And then the other thing that I didn't mention earlier, but our patients who received in-home care also were sent home with a home monitoring kit. So they were able to stay engaged, take their own blood pressure, temp, and pulse ox, and feel really a part of getting better and reporting that to us. That was reinforced in home visits, but was really, really successful at making the patient feel like, I'm in on this and we're going to get through this together.
And the one thing I would probably add, when you look at just admission rates from the ED, even from my hospital, the largest hospital, we are about a 30% admission rate out of our ED for those patients coming in. And so having the ability to have another care area for COVID patients was really advantageous to us, because if you think about just the psychosocial with the families, we did not have visitors for the longest time. We just recently let one visitor come in, but we still do not let visitors see our COVID patients or patients under investigation. So having another care setting for these patients makes it so much better for the families and for the patients and really for the care team, because they're not having to deal with the additional stressors. I don't know if Colleen mentioned, but the average daily census, or the census in the virtual hospital, is up, I think it's 1,500, right, Colleen, about that, what we see. So you're talking a lot of patients.
Wow.
Yeah, actually, we had a spike on Friday up to 1,750. So it did fall back to 1,500, but I do see that continuing to climb, at least for a while.
And I imagine that this is also a way to improve the access and really address some of the health equity issues in your community, because you can reach people where they are and not have them have to come to the hospital.
Absolutely. We've seen a real benefit for those in underserved communities particularly.
What challenges did you face as you were getting this off the ground? What were a couple of the big challenges beyond, sort of getting everybody on board with technology that you knew you had, but as you said earlier, you hadn't really deployed at scale?
Right. And we said this many times through the process. I think we are building the plane as we're flying it. And we had a lot of technology capability, but I would say a challenge was just to quickly deploy that technology to the staff where they were, because we used teammates who were in their homes. So that was a challenge, but went amazingly well. We had to quickly build protocols and procedures, and really more importantly, get them embedded in our EMR so that there was visibility for all of our care providers. Initially, we thought we were going to have to handwrite and scan into the EMR, but again, our IS folks were amazing and built these workflows, protocols, procedures into the EMR, and within about 48 hours, we were ready to go. Staffing is a challenge, always, and at the front end, it was great because Rob didn't need his nurses. We had stopped elective procedures. Only the most significantly ill patients were admitted at all. Our ambulatory practices had really reduced volume by at least half, so we were able to find nurses from ambulatory, inpatient, endo. Care managers helped us, our system resource team. It was a wonderful moment in time, but as we began to reopen or implement some of these elective surgeries and open up our ambulatory practices again, we've really been challenged with finding folks who could stay with us. And so we've, not surprisingly, used a lot of teammates who are not able to be patient-facing due to personal illness, pregnancy, or some particular reason. So that's been how we've been able to staff with both providers and nurses. And then just how to become a team. We were not able to meet in a room and whiteboard this out. We added people virtually, and they never had met before. So just the normal, how do you become a team and the rules of engagement that normally you can build when you can be face-to-face. We had to work, I think, extra hard to do that. You mentioned social determinants. So early on, our case mix, if you will, looked similar to what we had seen in inpatient care and even in our practices. But over the past several weeks, it has shifted heavily to our Spanish-speaking Hispanic community, which has presented a huge challenge. Those patients are testing positive at almost a triple rate of our general population, close to 25% right now. And most are not able to speak English, so we're struggling with that whole translation process. We have got an amazing translation team, but it still does take longer, and you're never as confident that the patient understands. So the Get Well Loop, while it has been wonderful for our English-speaking patients, it's not available really to do the whole process. We can send information in Spanish, but it has to be translated on the back end. So that's been a huge challenge for us. Supplies and equipment, we had to call in some favors, but we were able to get our home monitoring kits within about 3 days of issuing the request for blood pressure tip and O2 sats. Put those kits together on a weekend and rented vehicles, I'll mention, to deploy our home visit staff. Our paramedics and nurses had to lease some vehicles to get those folks ready to go. And I'll just mention PPE. Everybody in the country struggled with PPE, but we've managed to be pretty creative about how to spare that, and we've done okay.
Elisa, one thing that I do want to mention that Atrium Health did do is we kept our teammates whole through this whole pandemic process. You've read and seen a lot about furloughed and layoffs. We did not do that. We kept them whole. And one of the ways we did that is we created a pretty, I think, elaborate system where our teammates could be cross-trained, usually through technology, and that's ambulatory to inpatient, inpatient to ambulatory. And if they sign a claim that they could be reassigned, they were going to get paid through this pandemic process when we stopped our elective surgery. So as Colleen alluded to earlier on, when we started this, it was just a really great way to have teammates who sign that declaration to be able to cross-train them and have them do this work. So it was a win-win.
So, Rob, what are you doing now to sustain this effort? Although I know in North Carolina you're facing some increasing numbers, but how do you see it going forward if there ever is going to be a post-COVID world?
Yeah, great question. One of the things that we struggled with pre-COVID is that our capacity was about 102% on most days. So we had always struggled to get patients in our beds, working on throughput. So we're very, very interested in partnering with our virtual health team to see what diagnoses can go into the virtual hospital and not be in a bricks and mortar bed. We have looked at a lot of our observation patients. We have about 60 or so of our census, so not a large amount. We're 700, 800 beds here. But we do have patients that could probably be managed in the virtual hospital. We're looking at that. We're doing the business case for that because obviously if we're sending them to the virtual hospital, that will give us the opportunity to fill that bed with the patient that's more appropriate for a quaternary tertiary care facility as we are, so that we could have a higher complex patients in our beds and keep those patients that are lower acuity still need care and still need to be monitored and assessed, but giving them another alternative. So looking at that, I think Colleen mentioned something about our chronic care patients. We do have a great transition program for our chronic care patients. So I see this as kind of an interim step where if you couldn't manage them ambulatory in the traditional ambulatory model or the transitional care model, could you care for them in the virtual hospital so that the only solution will not be a bricks and mortar hospital? That to me would be a great benefit for us. As you mentioned, we are seeing an increase in cases, knock on wood, but our intensive care cases have been pretty flat. They peak up a little bit, but they go down. So being able to have this alternative for those less acute patients, I think is really going to be a win-win. We'd love for the payers to recognize this in a different way. As you know, I know AHA does a lot of work and lobbying for the hospitals on the different payer strategies, but this is one that I think really could be promulgated across the United States in a meaningful way.
Absolutely. Colleen, so what advice would you share with others who are thinking virtual hospital? This sounds like something we might give a try. Are there a couple of words of advice you'd share?
Yes, I have had the opportunity to talk to folks really all around the country who heard of it, more in the Southeast, of course, but we're well into COVID now, and some have actually passed the peak. So I don't know that it would be about COVID, but if we think about, as Rob just described, what other patient populations would benefit from something like this, I think you'd have the benefit of not being in crisis mode, which would be great. So just sort of in principle, begin with the end in mind. What problem are you trying to solve? What's the broad aim? And clarify that out of the gate, because it's tempting sometimes to just apply cool technologies and just see if it sticks. I think if you've been at this a long time, you got to think at a high level strategically first. What are we trying to accomplish? Begin with the end in mind. We wanted to make sure, just out of the gate, that the COVID patients received the care they needed throughout the course of their illness, no more, no less. That was sort of our rallying cry. We were able to assemble a team of people with qualities like flexibility, courage, diligent and hardworking. None of these folks seem to have their own agenda. All of the traditional silos and turf battles disappeared. I likened it to running a code in a hospital. Even if folks were fussing, earlier, respiratory therapy and nursing, when the patient's in trouble, it's all hands on deck. We were able to truly be flexible, brave, and everyone rallying around that common mission and vision. So I think even in a non-crisis mode, try to find folks that really can think beyond their scope of day-to-day responsibility. Real important to secure senior leadership. I guess that goes without saying, but oftentimes folks closer to the front line have wonderful ideas, and they begin to roll with that without first checking and making sure that senior leadership will support that. Be real clear about responsibilities and accountability. Though, as I mentioned, the silos really fell away. We did struggle sometimes with who has the ball on different things. And sometimes we say, I thought that Natasha was handling that. So trying to be a little bit prescriptive and disciplined around responsibilities and accountabilities and timelines, I would add, is really important. Identifying what you're able to do well. What are your inventory capabilities and resources you already have that you can redeploy differently. Goes against my grain to be so structured, but we were very intentional about meeting cadence, both formal and informal, to make sure that we were staying on task and true to our plan, which was well documented with, as I mentioned, accountabilities and timelines. And I guess the final thing I would say is get comfortable with ambiguity, because despite best planning and best efforts, they don't always turn out just as you anticipated, and some things just are not black and white. We got comfortable with failing fast and regrouping and pivoting to the next, and recognized that perfect was not absolutely necessary. We refined a lot along the way, almost daily, particularly in the beginning. So that would be my advice.
Great. Rob, anything to add to that?
No, I think communication is probably the biggest, particularly in large systems, because we have a fairly structured emergency preparedness in the way we structured our corporate command calls and the cascading of those. We were able to get information about this virtual hospital and get the information out pretty fast. As Colleen mentioned, she had to do different communication for her areas, but also we brought it back into the acute care calls. So we understood what was going on, and people knew about the mission of the virtual hospital and how it was going to be used. So I thought that was very helpful.
Great. Well, thank you so much for sharing your experiment with us, and best of luck in keeping it moving forward.
Thank you.
It was my pleasure, Lisa. Thank you so much for giving us this opportunity.